All right, hello everybody. So we're going to today do the second part, or a part two of our pharmacy law and ethics PowerPoint here, chapter 2 in the Pharmacy Practice for Technicians textbook. So yesterday we left off talking about adulterated and misbranded products. Okay, so just kind of a little recap there. Adulterated products are typically inconsistent in strength, quality, or purity They can be diluted with other chemicals that are either harmful or not harmful, but they're diluted with other chemicals that should not be in there. And then misbranded products are those that their label contains false or inaccurate information about the identity of the drug and its ingredients. So the Durham-Humphrey Amendment of 1951, this is a very important amendment because this amendment actually established the distinction between legend drugs, or what we call prescription drugs, or also referred to as legend drugs, and patent, which are non-prescription drugs. So patent went later on to mean brand name. Okay, so there was a little bit of confusion there. So when you hear the term patent, that is what is given by the FDA to drug manufacturers when they develop a new drug. They allow 20 years on a patent for new drugs coming out on the market. And the reason why that's so long is because it takes millions and millions of dollars and many, many years for these drug manufacturers to go through the process that the FDA requires them to bring a new drug to the market. And so they give them that 20 years to pretty much recuperate those costs. So unfortunately for us as the consumer or the patient, during this patent time on a new drug, so let's take the new drug that is used to cure hepatitis C. That drug is about $75,000 a dose, and typically patients need a dose a day for 12 weeks. So you do that math. Okay, so $75,000 a dose. It's very expensive. Insurance companies are covering it for the most part for these patients because it is a life-saving medication. But unfortunately, during the patent time, these drug manufacturers can charge whatever they want for these drugs. And part of why they do that is to recuperate the cost that they spent during the FDA approval process. The Durham-Humphrey Amendment also required prescriptions to be labeled with a caution label. And that label says, "Caution, federal law prohibits dispensing without a prescription." So in 1951, this caution label was now put on all prescription labels of bottles that were being dispensed to patients. So it was making a clear indication that the bottle and the prescription that was being given to the patient, and whatever it was, whatever drug, anything coming out of the pharmacy through a prescription had to have the caution label saying that this drug can only be dispensed with a proper prescription. This amendment actually also allowed pharmacists to begin taking refill orders for some medications over the phone. So prior to 1951, this was not allowed. And once the Durham-Humphrey Amendment of 1951 was passed, some medications, it didn't allow it for all of them, but some medications were starting to be allowed for pharmacists to take those refills over the phone. The Kefauver-Harris Amendment, this one you will be in the next couple days, maybe even to next week, I haven't decided yet. You're going to be watching a pretty interesting documentary on this drug that was responsible for the passing of the Kefauver-Harris Amendment in 1962. So this amendment was passed in response to the thalidomide tragedy, is what we call it, or the drug thalidomide's association with birth defects. So this drug was used, is actually a sedative, and it was used primarily overseas in the European countries. as a sedative. And so one thing that started happening was they had pregnant females who were taking this sedative and realized that, oh wow, this is working really well for my morning sickness. So instead of them doing clinical trials to ensure that there was no risk or harm going to be caused to the babies while they were still in utero, they went ahead and just started prescribing it for all pregnant women who were experiencing morning sickness. And so what started happening was, as around the time, 9 months from the time they started dispensing this medication to women for morning sickness, they started to notice and see that babies were being born with some severe deformities. Thalidomide typically affected only the limbs, so the arms and the legs. And the interesting part about thalidomide and the degree to which it affected babies during their developmental stage was it depended on what week within the pregnancy that the woman took the medication, and that determined which limbs, so either the arms only, the legs only, both arms and legs, and how severe were affected depending on the week of pregnancy that the woman took the medication. So as we watched this unfold from the United States, we had some doctors that were already in and ahead of the FDA and pushed to prevent thalidomide from being marketed and sold in the United States for morning sickness. And that's what pretty much saved the United States and the babies within the United States from having these birth defects. So most of the cases happened overseas. As a result, as a result of the tragedy of the thalidomide that was unfolding overseas, we in the United States, through our legislation, passed the Kefauver-Harris Amendment. And this, as a direct result from the thalidomide tragedy, it requires that drugs are not only to be proven safe, but effective as well. So they have to go through the human clinical trials to prove that they're safe and that they're effective for the use that they are going to be marketed for. So for example, if I'm bringing out a new blood pressure medication, I, as the drug manufacturer, have to do clinical trials to prove that that drug is safe for human consumption and that it is effective for lowering blood pressure. Okay, so it must be proven safe and effective according to the Kefauver-Harris Amendment of 1962. It also provided patent protection for name brand drugs that were proven both safe and effective. So again, this one tailored into the patent protection of the 20 years for drug manufacturers bringing out new drugs to the market. The Comprehensive Drug Abuse Prevention and Control Act of 1970. So this act is actually also called the Controlled Substances Act, or the CSA, is another term that they use to refer to this act. So this act is the one that's responsible for ranking the controlled drugs into the 5 schedules, so C1 through 5. And I'm going to put a little thing up here for you. All right, so the Controlled Substances Act, or the CSA, and I'll turn that back when we get ready to that. So they ranked controlled substances into 5 different schedules. And so what they determined, or how they determine what drugs are placed into these categories, is based off of 2 things. It's based off of medicinal use, and then it's based off of the abuse potential. So when we look at C1s have the highest abuse potential, but they have no approved medical use. Okay, so no approved medical use. I hope you can see that. C2s are basically the second highest abuse potential, but they do have approved medical use. Okay, third highest with the same, fourth highest, and then the fifth highest. So C2 through 5 all have medicinal use. Okay, so C2 through 5s have medicinal use, and they are ranked by highest abuse potential. So in C1s, okay, we're talking about things like heroin, meth, illegal meth, LSD, mushrooms. I don't do street drugs, so it's taken me a minute to think. Marijuana, actually. Marijuana, still according to the federal government, is a C1 drug, even though certain states have approved it. Even though certain states have approved it for medicinal use in their states, still according to the federal government, it is a C1, which makes it an illegal substance. So, C1s, highest abuse potential, no medicinal use. C2s, the second highest. So they basically have the highest out of C2 through 5, but they have medicinal use. So in this category, we're looking things at like fentanyl, Oxycontin, morphine, Dilaudid, Demerol, all of these very high potent opioids. C3s are a step down from C2s. They still have a high potential for abuse. They do have medicinal use, so things like Tylenol 3, which is Tylenol and codeine, and testosterone. C4s are a step down from C3s. They still have an abuse potential. They do have medicinal use. And things like this would be Valium, Xanax, Ativan, Tramadol, things like that. C5s are the lowest abuse potential out of the 5 schedules. They do have medicinal use, and these are things like Lyrica, which is used for nerve pain for patients that suffer from fibromyalgia, Lomotil, which is an anti-diarrheal medication, and so from there, these drugs, depending on their abuse potential, are categorized into these 5 categories. The controlled or the Comprehensive Drug Abuse Prevention and Control Act of 1970 is what established these 5 schedules. So I'm just going to put up here some of the examples that we talked about. Just a few to give you All right, so I got some of those up there for you. So if you want to just, play back this video in a few minutes to write those down, you can. So again, this specific act of 1970 established these 5 controlled schedules and determine how drugs are classified and meet the qualifications to go into those 5 things. This act also paved the way for the establishment of the DEA, which regulates who can prescribe controlled substances. So the DEA oversees controlled substances only, where the FDA oversees all drugs, whether they're controlled substances or not. The FDA oversees those. But in terms of regulation of controlled substances, how many refills they can get, how are they prescribed, who can prescribe them, what pharmacies can dispense them, that is left, those regulations are left to the DEA. The state boards of pharmacy can also control or regulate the controlled substances. They kind of piggyback off of the DEA, and they can make more strict control or requirements. And those are going to vary from state to state. For example, in some states, we've talked about this before, those of you that have been with me for a couple sequences, in some states, not Arizona, but in some states, you can purchase 4 ounces of a codeine cough syrup over the counter without a prescription, 4 ounces in 48 hours. So in the state of Arizona, you cannot. So the DEA says yes. Okay, the DEA says yes, we're fine with it. But each state has either said, yeah, we'll go with the DEA, or in Arizona's case, they said no. State of Arizona, we're going to require a prescription for it. So in this case, you're thinking, well, which do we follow? Do we follow the federal law, which is sent by the DEA, or do we follow the state law that is determined by the Arizona State Board of Pharmacy? Whenever it comes to pharmacy and laws and which one you should follow, you will always follow the more strict law. So in this case, the state law is more stringent or more strict. We follow the state law. Okay, so if the roles were reversed and the state said, well, I don't really care, but the federal law said no, it requires a prescription, the federal law supersedes because it is more strict. That's how pharmacy operates across all 50 states. They will always follow the more strict or the more stringent law. The DEA also determines specifically what types of physicians or what type of healthcare providers can prescribe controlled substances. Now, these prescribers, whether it's a dentist, a physician, nurse practitioners, veterinarians, there's more in your chapter that you have to identify in your daily assignment, but those are just some of them. These individuals must register with the DEA to get a DEA number. They have to have a DEA number in order to prescribe controlled substances. If they do not have a DEA number, they cannot prescribe controlled substances. The same goes for pharmacies. Now, pharmacists do not need DEA numbers, but a pharmacy facility needs a DEA number to be able to dispense controlled substances to their patients. So again, I'm just going to go through, there's a nice little chart on slide 16 that goes through these 5 schedules. And again, it ranks it in the abuse potential, but also for medicinal use. So it says for Schedule 1s or research only, facilities must have a license to obtain these, and typically these are research facilities. So research facilities that are trying to figure out if marijuana truly has a medicinal use, they would have to have access to the drug itself to be able to do these trials and these experiments. C2s, again, highest possibility of abuse underneath the C1s, but they have medicinal use. The dispensing is severely restricted, so they have 0 refills are allowed on C2 medications. They cannot be prescribed by telephone except for an emergency situation, and that's very rare. And again, they have no refills. So C3s, again, less potential for abuse and addiction than the C2s. These can be called in. So C3 through 5s can be called in, and they're allowed to be refilled up to 5 times or 6 months, whichever happens first, and as long as that's authorized by the physician. C4s are exactly the same, and C5s have the lowest abuse potential. And again, some C5s, particularly codeine-containing cough syrups, are sold without a prescription in certain states to individuals 18 years or older. and it does require them to show photo ID for proof, and there's a whole process that takes place in how that is dispensed and what information is collected by the pharmacy when they're dispensing this without a prescription. But we're not going to focus on that because we're Arizona, and Arizona doesn't allow that. So prescribers of controlled substances, again, they must get the approval and the DEA number from the DEA, and then the DEA from that point on will monitor them. Some of these practitioners include physicians, physician's assistants or PAs, nurse practitioners, dentists, veterinarians, and even podiatrists. Some pharmacies may not be licensed to fill Schedule II prescriptions written by an out-of-state physician without verification. So certain pharmacies have to have licenses to be able to fill C2 medications written by physicians out of other states. So sometimes, let's say a patient has a prescription that they got and for whatever reason had to leave town and go into a new state, they may or may not be able to get that prescription filled. Now, no pharmacy in all 50 states can fill a controlled substance prescription written by a foreign doctor. So if the foreign doctor is not practicing or licensed in the United States, the pharmacy cannot fill controlled substances for that. One thing to tailor back to real quickly regarding the calling in an emergency situation for C2 medications. Now, that is allowed, and again, for only emergent situations. And what deems an emergent situation is kind of left up to the physician and the pharmacist. But what has to happen after that, so let's say a physician calls in an emergency prescription for oxycodone, the pharmacy fills it. Within 72 hours, it is a responsibility of the physician to get a actual hard copy, written copy of that prescription delivered to the pharmacy. So they have 72 hours to do that. And that's pretty much standard across all 50 states. Some of them give them a couple more days, but it's kind of tightening up, especially with our opiate crisis. And that's within 72 hours. They have to have an actual handwritten prescription for that verbal order delivered to the pharmacy to put on record. So we have covered from where we left off last time through slide 17. This is a really interesting section, so I want you to read that next part in your chapter, in chapter 2 from that page forward. And the pages don't match up to the slides, but you're going to get through the very end of the Comprehensive Drug Abuse Prevention and Control Act, which talks about the prescribing, and then you're going to go ahead and stop there and go ahead and do your daily assignment. We will continue on with part 3 for Wednesday, and I hope you guys have a good rest of the day.